Good afternoon and welcome to our webinar, COVID-19 as an opportunity to strengthen health systems governance. Governance is defined as the way we make and implement collective decision, and clearly it has shown to be very, very important during the COVID-19 crisis because governance has proven to be a lever for mobilizing, for example, the health workforce, for changing hospital delivery systems in general, for mobilizing monies to fight the pandemic. And of course, we've seen so many interesting governance responses to COVID-19 that it is really overdue to draw a couple of lessons from it, what we can retain for strengthening health systems and health systems resilience in the future. And you just see on this slide the EuroHealth special issue we have prepared for the WHO Regional Committee this September. It's downloadable from our website, and you see the different topics. And we will zoom into some of these topics today. And to do this, we are very happy to announce that we have as a keynote speaker today, Natasha Azzopardi-Muscat. She's director of the WHO Regional Office in Europe in Copenhagen, and she will tell us about leadership and governance in the pandemic and what we can learn from it for strengthening health systems. We will also have a colleague from WHO headquarters in Geneva, Kira Koch. She will talk about governing civil society, governing non-governmental organization, and that will be followed by spotlight speaker Florian Tiller from our own colleagues from the Observatory Hub in London. He will tell us that public-private partnerships are not just a choice, but a necessity actually to respond to the pandemic. And finally, our third spotlight speaker today is Professor Jim Buchan. He's editor-in-chief of Human Resources for Health, and he will talk to us about governing the health workforce. Just a couple of things to mention with regards to the housekeeping. Please use the chat, whether you have comments or questions, just put it into the chat. My colleague, Erika Richardson, later on will bring this to the forefront and feed your comments and questions to the speakers, to the panelists. We are going to record this session, so it will be very soon available on our YouTube channel. And please, right after the session, an evaluation form will pop up. We would be very grateful if you could fill this in. That is very, very helpful for us. Just one thing before I hand over to my colleague, Erika. Natasha Azzopardi will be with us just for her keynote, so she has to go after 20 minutes, but we have excellent speakers today and I think a lot of food for discussion. And now I would like to hand over to Erika. Erika has prepared a poll. Please, Erika.
Yes, Annalisa, if you could put the poll up on the screen, that'd be fantastic. So just a couple of questions for you today, just so we can get a feel for who's in the audience, and that sort of thing. So it is anonymous, so just to be reassured. But the first question is, did your country go into the pandemic with robust government structures in place? And then the second question, which is a multiple choice question, you can give 2 or 3 different answers if you like, is where have the main gaps in governance been in your country during the pandemic? So were the gaps in political leadership or intersectoral working, human resources management, public health leadership, procurement, or none of the above? Okay, so looking forward to hearing your answers, and after Natasha's given her talk, I'll feed them back to you. Thank you.
Thank you so much, Erika, for these questions. And now, Natasha, the floor is all yours, please.
Good afternoon, Matthias. Thank you very much for hosting this webinar, and it's really my pleasure, as always, to team up with colleagues at headquarters, at the observatory, and today we have this really important topic, which is a difficult topic. When we talk about governance, the word itself sometimes scares people, puts people off, mystifies people. But I'd like to think that through our special issue, we have tried to give a very pragmatic sense to what we mean by governing health systems during the time of COVID, and more importantly, the lessons learned. So just I try to put it as simply as I can. When we talk about governance, it's really the way in which we make and implement collective decisions. We know that governance is often best noticed for its absence, because without governance, we can't enable effective health policy development and implementation. Particularly, this becomes very visible during times of emergencies. But in our day-to-day routines, having the right governance in place can prevent things from becoming a crisis or an emergency. Of course, there's a real gem. There are many gems of articles across the whole issue. But today I will focus drawing mainly on a couple of articles that I have been involved with colleagues working on, and I delivered this presentation also on behalf of my colleague Govem Permanent. And I would like to focus particularly on public health leadership, emphasizing why we need to go beyond the traditional comfort zone and particularly take a wider lens and approach. So one of the questions that we ask is, why has there been so little correlation between the assessments of countries' readiness plans and actual outcomes? And of course, you will all know of notable examples of countries that scored highly on the preparedness index, and then when it came to the actual outcome, there were gaps in the response. I will refer to an important statement made by UFA and ASPER that drew conclusions last May about the parallels between having strong health leadership, and that countries with strong health leadership were better able to design and respond in a rapid and effective manner. Of course, this is not surprising. But perhaps one of the questions that remains a little bit unanswered and deserves more attention is, given the harsh and inequitable impact of COVID-19 with a disproportionate effect on those most vulnerable, have decision makers, including ourselves as public health decision makers, taken a wide enough approach and taken a response strategy, a wider societal perspective into our response strategies? So, coming to the next slide, our analysis shows that, or leads us to think that the key issues undermining public health issue leadership, we drew out a series of issues which we called legacy issues. In other words, they were there before COVID, and COVID, as it did with so many other things, merely amplified them. And the first one is the inexorable erosion of public health in Europe, and the Observatory had published a fantastic volume pre-COVID documenting, in fact, the difficulties that public health systems in Europe were facing, particularly after a decade of austerity in certain countries led to underfunding, fragmentation, and with this comes the loss of authority and voice. Another point which emerged was the fact that we do have silos, and the public health workforce was often siloed off from the clinical health workforce in those countries, for example, where at the level of primary care, also in hospitals, when it comes to social care institutions, public health was really working across the silos in partnership, the response was better coordinated. And this, of course, leads then to the key point, which is public health needs to be networked everywhere to be able to interact with other sectors and enact health and all policies. And the pandemic has really shown this, not least with the work around schools, but even more broadly, for example, when it comes to travel and tourism. And public health really needed to work closely with those sectors in a way that perhaps we hadn't been used to doing before. And of course, the elephant in the room is the politicization of public health issues. It would be naive to think that public health is apolitical. I've always been a strong proponent of the fact that public health is inherently and intrinsically a political activity, not least in times of crisis, but the negative use of politicization of public health, of course, does not allow public health to execute its functions serenely and effectively. But holding a mirror perhaps a little bit to ourselves and asking ourselves, what has eluded us from a governance perspective during the pandemic? And we believe that there were two gaps. The first one being the lack of a clear goal. We tended to waver from containment to suppression to elimination, to then say, well, this is not possible, and let's find a way to just work with the virus. I think public health often tried perhaps to achieve goals that were somewhat unrealistic, only then to find itself being pushed back into a position. And in a sense, we didn't set ourselves clear targets early enough. Of course, I don't want to be too hard on ourselves because this was evolving and there was a lot of uncertainty, but perhaps more cohesion around targets and goals that could then be clearly communicated to politicians, to the general public, to healthcare professionals, would have avoided some of the mixed and inconsistent messaging that we saw. So moving forward, we propose that in terms of better governing and leading during a crisis, we need to take a health and all policies lens, even during a time of emergency. And this means moving away from a pure focus on infectious disease epidemiology, on case numbers, on R values. And in fact, as WHO Regional Office, some months ago, we published a dashboard that takes a much wider view on how one needs to manage a pandemic, looking also at the health services, the routine health services, disruption of health services indicators, and the wider societal well-being indicators too. Identifying early on what is really triggering the spread and going beyond the numbers, so to say, accompanying that epidemiological and statistical approach with an ethnographic and qualitative approach. And when I talked earlier about the focus on maintaining essential services, we are seeing, for example, the dual pandemic now emerging with mental health. And clearly, if you want to retain a modicum of control in an emergency situation, one cannot afford not to have mental health very much on the radar. How do we do this? By taking a community-anchored health promotion approach alongside the health protection approach. So coming to the next slide, please. How can we reinforce public health in Europe? And of course, here we propose a series of key actions, and we are working closely with our colleagues in the observatory to actually try to study some of the gaps that occurred in public health leadership and institutions, and draw some lessons. The first one is that we really need to make a case to strengthen public health institutions with secure and stable financing, starting with WHO itself, but very much also at the national, subnational, and local level too. If we can't make this case now, I'm afraid we will never be able to make it. Secondly, we need to really build the leadership capacity for public health across the health workforce. And here we're working very closely with our sister organizations. Thirdly, we need to acknowledge the necessary and diverse contributions from other stakeholders. This is too large for us to do alone. And this is why we also need to engage stakeholders early on. And finally, and this is really important, it's about really breaking down the silos, moving out of our comfort zones and engaging with and across other sectors. Next slide. So what are we doing? Even pre-pandemic, when we established our European program of work with two overarching objectives, one of these two objectives is to strengthen leadership of public health authorities at country level. And of course, this needs governance foresight. We need the courage, the creativity, and the ability to learn to really make progress on universal health coverage, responding to emergencies, and ensuring healthy lives and well-being for all. These are the 3 pillars of our European programme of work, the same pillars that we find in the general programme of work. And very recently, of course, we launched the Independent Commission on Health and Sustainable Development, convened by the Regional Director Hans Kluge, WHO Europe, and chaired by Senator Mario Monti, with the excellent accompanying evidence review edited by Professor Martin McKee and published by the Observatory, has 7 objectives. And I'd just like to say that across each of these objectives, whether it's governing One Health, whether it's tackling the fractures in society, whether it's ensuring we have innovation in our health systems, creating strong and resilient health systems based on the back of the lessons we have learned, creating an environment that really promotes funding and investment in health, and then at a higher level, the governance at European and the global level, but really and truly at the heart of all of these objectives, and I invite you to read the report and the evidence review, is a strong thread on health leadership and governance across all sectors. So to conclude, if I come to my final slide, I would like to thank you very much for having given me this opportunity to share these few thoughts with you, very much inspired by the work that we did for the preparation of the special issue, but work that will no doubt accompany us both at regional level and within countries as we seek to go forward and render this health governance objective, which is so necessary for resilience, in a very pragmatic way, something that can be worked upon to do better before the next pandemic comes upon us, and to help build our health systems that are very much still focused on the pandemic in certain parts of our region more than in others, but also seeking to recover. Thank you, and back to you, dear Matthias.
Natasha, thank you so much for this excellent keynote, this wonderful overview. And as you said, usually governance is kind of invisible, but now in the crisis, you know, everybody could see whether governance work or doesn't work. And also thank you so much for not only pointing out some of the deficiencies we have seen during the various waves of the pandemic, but also being very clear and practical about the way forward and what could be addressed. And I think in this context, we should really look towards the Monti report. 2 out of 7 objectives are really focusing exclusively on governance, and you could also read the whole report as being mainly on governance. It's wonderful to have you with us, but we fully understand, Natasha, that you have to go now. I'm quite sure that we will have a very interesting panel discussion. I already saw quite a number of contributions in the chat. So thank you so much, and have a great day. Erika, it's now time to present the poll results. What can we see from the questionnaire?
Yes, Annalisa, if you could put the results up. So interesting results. 2/3 of the respondents felt that their countries had not really gone into the pandemic with robust governance structures in place. And where the weaknesses are, it's pretty much across the board, but very much in human resources management. So I'm very, very pleased that Jim Buchan will be talking about this later on. But yes, everything seems to have been an issue during the pandemic. So thank you very much for that, everyone.
Yes, and it echoes actually a bit what Natasha was saying, that even countries that thought they were well prepared for an event like the pandemic, in the end, it turned out that they were struggling and had difficulties with their existing governance structures. And so we should use the COVID-19 lessons really as an opportunity to improve health systems and care governance. Thank you so much, Erika. And now, without further ado, I would like to ask my headquarters colleague, Kira Koch, to give us a spotlight on governing civil society. Kira, the floor is all yours.
Good afternoon, everyone from my side. My name is Kira Koch. I'm part of the Health Systems Governance and Financing Department at WHO headquarters, and I would like to use the next 5 minutes to go into the first spotlight topic, which is on civil society and community engagement during the COVID-19 response. You can find the full article in the EuroHealth special issue. And let me mention, first of all, that that was really a joint effort from colleagues from WHO, WHO Euro, EFER, the European Public Health Alliance, and EuroHealthNet. So for this article, we conducted a fairly simple and rapid survey to gain a better understanding of the government civil society collaboration over the course of the pandemic. This does not allow for any representative conclusions. However, it did reinforce findings from a global 2020 survey and WHO's ongoing country support work. And for today, I would like to highlight 4 key points. First, civil society and community actions largely remained independent from the COVID-19 response, underlining that collaboration with civil society was largely perceived as an add-on based on civil servants' willingness and availability to collaborate, rather than an integral part of the COVID-19 response. Second, the lived experiences and inputs from civil societies were not adequately brought into COVID-19 decision-making. And this could have helped governments to better understand risks, in particular of vulnerable population groups, and to gain more adherence to public health measures and vaccines by working with trusted groups. Third, the ad hoc nature of engagement with little or no follow-up by government authorities was most common, according to the respondents that you can see exemplarily on your screen. And lastly, there was no substantial improvements in engagement modalities over the course of the past 18 months. So despite some good examples of cooperation, we've seen largely limited inclusion of civil society and community groups in the response. Yet many researchers and policymakers have particularly pointed out to the importance of community engagement. So why was it still so often neglected? And what can we learn in order to build back better and to create more resilient health systems that can address the needs of the communities it is meant to serve? Very short answer is we need to heavily invest in social participation mechanisms. And by that, I mean moving away from an ad hoc nature towards a regular institutionalized mode of government engagement with civil society and community groups, both in crisis time and beyond. Yet when we talk about governance, we also need to talk about power and power imbalances and how we can mitigate power imbalances among actors for meaningful participation. And enabling such a participatory environment is not an easy task. It takes time and it requires political will and prioritization. It also calls for a shift in mindset, which recognizes that meaningful interaction is fostered when policymakers make visible efforts to listen and also accept that they may not have all answers to health systems challenges. In essence, it's about creating a space where not only the most influential, but also the less powerful have a real opportunity and feel safe to express their views and experiences. However, what we can see in countries is that the skill needed to foster such an environment, to create, to manage, and to sustain participatory processes is one which many government cadres have yet not been adequately trained in. For example, recognition skills, the most fundamental, but also the most difficult to build. Here it's about understanding the added value, but also understanding it as an essential part to health policy and policy making. Technical skills, here in particular for mid-level servants to know how to design and facilitate participatory processes. And also lastly, communication skills, the ability to leverage different communication channels to hear from the population, not only to listen, but also to provide feedback after consultation. So let me conclude. It is important to invest heavily in social participation mechanisms, as these can provide a platform for meaningful engagement and ensure that post-COVID-19 health systems reform does indeed build back better, as it contributes to strengthening the very fabric of society, building the resilience needed to lift us out of the current, but also prepare us for future crises. Thank you so much, Matthias, and over to you.
Kira, thank you so much. I think we cannot re-emphasize enough how important civil society and community is actually, not only in the times of the pandemic, but also in rather normal times. They make a immensely important contribution to policy making. You know, they have first-hand knowledge of their constituency, of localities, but they're also very important when it comes to service delivery. And last but not least, with their self-governance capacity, they unburden governments actually and can really, really support them. And you've now shown a couple of issues that we don't have actually the institutionalized platforms in some countries to work with them systematically. And this links back to what Natasha was saying, that we need to strengthen our institutions and build more capacity. So thank you so much, Kira, for this. And that is the moment to go to our second speaker, my colleague Florian, who sits actually in our London hub. Florian, tell us a little bit about public-private partnership and what we've learned with regards to governance and the COVID-19 crisis. Floor is all yours.
Good morning, good afternoon, everyone. As I was kindly introduced, my name is Florian Tillen. It's my pleasure today to present to you our findings on governing public-private partnerships, or I will call them PPPs in the following, during the COVID-19 pandemic. Just to mention this up front, this also has been a joint effort by colleagues from the Observatory here in the UK, in Belgium, in Germany, together with colleagues from the Ben Gurion University in Israel and from Health Austria. We also developed this piece as a product for the EuroHealth joint issue that we've heard about earlier. So diving right in, just to remind ourselves here that when we talk about governance, we have to consider 4 sectors, being public, private, civil society, and academia. Kira just very nicely alluded to the civil society one, and I'm going to look at the intersection here between the public and the private sectors. I'm really trying to distill the paper that we've developed, and which I will reference at the very end, into 3 key messages that I want to present to you now. We can consider it as working hypotheses, really, and then look into whether they might spark some kind of discussion later in this meeting. So firstly, our message here really is that PPPs were essential in the emergency response across Europe, and essential really being in the pure meaning of the word. PPPs were not an option really, but a necessity to boost capacities across many countries. And without them, the response definitely would have been a lot weaker. Many of the partnerships we've seen between public and private actors really worked efficiently to provide testing and laboratory capacities, to provide develop applications for surveillance and monitoring, to provide PPE and ICU search capacities, and also to accelerate research and develop and deploy, not at the very least, COVID-19 vaccines. Some striking examples were from the UK, the development of the NHS COVID hospitals, so to increase search capacity, sewage monitoring in Israel, and surveillance via a COVID tracing app in Austria. In a sense, those examples have shown that different PPPs have contributed to containing, mitigating, and suppressing COVID-19, and have demonstrated the potential for outcome-focused, creative way towards public health goals. Here, however, comes the obligatory but. We have seen that in design and practice, a range of those PPPs have shown poor governance. And this can be pinpointed really towards a lack of transparency, accountability, participation, and overall efficiencies that have become apparent. Some very infamous examples I want to highlight here are one from the UK and one from Israel. In the UK, some of you might have heard the case that very early in the pandemic, in March 2020, already the national government was looking into expanding the supply of PPP across the NHS in the UK. And this process was largely successful. However, there has been quite a lack of transparency about the contracts that have been awarded to the PPE suppliers, and with many of those being awarded without any kind of competitive tendering or without even being published. This was further exacerbated by the creation of a high priority lane for potential suppliers that could be suggested by ministers, members of parliament, and other officially elected officials, which resulted in contracts for a much higher proportion of those suppliers than those that were identified through the normal lane, so without any kind of contacts to those officials. The cost of the PPE purchase also was significantly higher than before the pandemic. In Israel, there was an example on the agreement that we've seen between the government and Pfizer to provide vaccine to basically cover the entire Israeli population very early on in the pandemic, and through which Pfizer gained relevant data that facilitated the completion of the phase 4 of the vaccine trial. Several NGOs and think tanks in Israel have raised serious concerns about what the contracts actually comprise, what they say, because they haven't been published for the largest part, who owns the data of the people and who will actually gain from this agreement. So in short, in the absence of really effective governance mechanisms, some drawbacks of PPPs can include an unbalanced risk sharing with a much higher chance of wasting public resources while still being profitable for the private sector. And further to that, also creating hidden debts, corruption, distorting public health priorities, among other things. And on this very last point, on the distorted public priorities, I really want to pick up my third key message now, which is that we're relying on rather poorly governed partnerships in the long term can weaken existing public structures, which are, again, commonly the main foundation for the public health response, both during but also post any kind of emergencies and preparing for the next emergencies. So while streamlining processes are appropriate during an outbreak, and there may be quite a value in more flexible forms of cooperation between the sectors, poorly governed procedures and risks raise issues of equity, privacy, value for money, and overall health system performance. We especially need to look at social and health equity here, because this can lead to wider society aspects. Really wrapping up, as much as pre-pandemic, it's pivotal to increase transparency in any kind of arrangement, not only because it's a value in itself, but because it only is also very much linked to other principles of good governance, such as participation, accountability. So really to wrap up, novel PPPs during COVID-19 in Europe were an opportunity to learn from this emergency period, also for reshaping governance frameworks for the future. Thank you very much for your attention, and this is the reference to the paper.
Florian, thank you so much. And for somebody like me who's not an expert in public-private partnership, it's a bit of an eye-opener, because usually I think about hospital investment or large infrastructure, but in reality, private-public partnerships are everywhere, not just in the pandemic, they are also there in regular times. And what you've been saying, and I know you had to be very brief, is also questioning whether we need to change some of our procurement procedures actually to be quicker, but also transparent and very, very reliable. Thank you so much, Florian, for your spotlight on public-private partnerships. And now, last but not least, I would like to invite Jim Buchan. Jim Buchan today is here with us in his role as the chief editor of Human Resources for Health, but many of you know Jim Buchan in very many other roles. He's a professor, of course, and he's been a long-time consultant for WHO and many governments across the world on the health workforce, and he's a long-time collaborator with the European Observatory as well. So Jim, please fill us in on governing the health workforce.
Many thanks, Matthias, and good morning, good afternoon, everyone. Very briefly, I'm going to try and go through some of the key issues related to health workforce responses as enabled by governance and governance changes during the pandemic. I've got 3 slides, and the first really picking up on Natasha's excellent introduction is just to give a fairly pragmatic definition of what we mean in terms of governance of the health workforce and care workforce. And this is very much reflected in the article in EuroHealth. We identified 4 areas of response, all of which are necessary and all of which were evident in a range of countries across the region and beyond. Firstly, there are policy changes from national or regional government, and we need to recognise that some of those focused specifically on healthcare, but there were also responses across other aspects of government, such as education and employment, which had an impact on health and care workforce itself. The second one, which was very prominent in some countries, was either legislative change through introducing new legislation or suspension of current legislation in order to, for example, allow changes in working hours or other cadres of staff to prescribe. A third area was looking at health professional regulation. For example, some countries enabling student doctors and nurses to work on the front line required regulatory change. And finally, looking at the role and the remit of employers and managers. And this varied a lot depending on the type of system. In some countries, the government is also the main employer. In other countries, that's not the case. So looking at, for example, pay incentives to encourage or support workers in particular areas of the countries, one example. We characterize those very much as institutional areas, but we have to recognize that essentially they are functions and they are distributed differently in different countries, and that's got to be more thought through in terms of responses at country level. Moving on from definition to really what happened, what was evident, and we cover this in the chapter in EuroHealth with specific country examples. One of the critical and very high profile and obvious areas of governance response was to support, create surge capacity. That was about rapidly scaling up the number of workers, retraining some, redistributing others in order to meet the identified demands of pandemic impact. And this has been a very prominent area across countries, and to some degree has eased off in some, but it's still there. There's still a recognition that we need to look at how to optimize the available workers to meet changing and growing demand. The second equally critical issue that emerged very rapidly and continues to be a big priority, and that was protecting the workforce's health and well-being. Heard already from Florian about PPE and the need to ensure that was available. That was, in many countries, the immediate high-profile governance issue related to workforce. But what has emerged through and beyond and is very prominent now is looking at the health and well-being of workers who have been under a huge strain, huge workload increases, risks of burnout, risks of mental and physical health and well-being issues. For example, in our chapter in EuroHealth, we report on policy response in Ireland to try and ensure that health and well-being is being covered and will have to continue to be covered. One of the main messages about health and well-being is that the impact of the pandemic on the workforce is with us, but will continue to be with us for the months and years ahead in terms of how individuals have responded to the challenges they faced at work. More recently, the vaccine rollout has required governance input. In some countries, this has been about rapidly training up other workers to contribute. It's been about reallocation, redistribution of workers to get to the point of vaccination. We give the example of Israel in the chapter in EuroHealth. And finally, there is the huge and growing issue of recovery, and I'm really linking this to continued preparedness for whatever comes next in terms of other pandemics or a resurgence of this pandemic. Final slide, just in terms of looking at recovery and preparedness, 3 takeaway messages. Workforce is at the core of the recovery in any health system, and if we have weak governance, that will inhibit recovery. No health without an effective workforce. That's number 1. Number 2, the pandemic responses have exposed and challenges to existing governance barriers, many examples of this. And the question for all policymakers in all countries is, how can we embed the positive governance changes that have occurred so that they continue to be enablers? And examples include new scopes of practice, new use of digital health, etc. And finally, final takeaway message, protecting the workforce in order to protect the system. If we don't have systems and governance in place to ensure the long-term health and well-being of the workforce, we're not going to be able to sustain effective recovery. Thanks very much.
Jim, thank you so much. And I think the message is very clear. If we don't address those governance weaknesses, we will have great difficulties to find good recovery responses to the crisis. And also, I think it's now clear why usually governance is not really very visible, as Natasha was suggesting, because, we still follow the policy-making process, but then the cumbersome process of converting policies into legislation and then regulation and then maybe even industrial relations or change strategies, change management strategies at the shop floor. We usually don't look at them, but you make quite clear that we need to go through all these levels and that governance is not just the policy making, but it goes much further and we need to work at different levels at the same time. So thank you so much to all the spotlight speakers. Also, thank you so much for respecting the tight time budget. And I already saw that there are plenty of comments and questions coming through the chat. So please, speakers, switch on your cameras. And Erica, feed us back what you've seen in the chat.
Yeah, we've had some really interesting questions in the chat. So firstly, there was a sort of like comment about the governance issues when it came to coordination between public health structures and health system structures, and if there's any insights into that you'd like to share. Secondly, someone asked how, given that we should be working with people and not at people, how can we engage citizens to take a more active role when it comes to sort of pandemic response? And then one last one, so hopefully we'll get 2 rounds in, but does anyone have any insights into health governance and the impact it's had on health equity issues, that particularly those that have been highlighted by the pandemic? So any insights on particularly good practice or things that we can learn from in relation to that? So over to you.
Very good questions, Erica. Thank you so much. And we certainly have a second round of questions, but maybe we can just start with you, Kira, please.
Yeah, thank you so much, Matthias and Erica. Let me get to the question on active civil society, communities and population engagement. And I think that's a very important question. And I think this is what I alluded in my presentation as well. Yes, of course, we need risk communication and community engagement mechanisms, also called the RCCE, during a pandemic response. But what we are trying to advocate for is also to invest in social participation mechanisms, not just only during a pandemic, but for health efforts. And particularly this because we know that it's very difficult to build trusted relationship during a response. So using those established mechanisms, which then can be reactivated during a response, does actually allow for more meaningful engagement, collaboration, because we have already the contact person that we know, that we can trust, and with whom we can work together. And maybe lastly, if you allow, on the question on health equity, and I think that's a very important one too, since we have seen with the pandemic entrenched inequities, especially or disproportionately affecting most vulnerable population groups. And I think here civil society and community groups can play a very active role, maybe we would say a missed opportunity, because we haven't taken the inputs and the knowledge, the experience, lived experience from those groups into account in order to elaborate and implement more effective policies and social measures that respond more to the needs of the population.
Kira, thank you so much. I think we had quite impressive examples a couple of months ago when we were talking about civil society. And I remember something on prison health and another one on working with the travelers communities. And it was exactly, you know, including civil society, giving them a voice and participating and engaging with them. I think they are very good examples, even though your research has shown that at the moment across Europe, the situation is not so great. Florian, please.
Thank you very much, Matthias, and thanks for the question also coming in. And yeah, the one that I would like to address right away really is the one on equity as well, because I think, as Kira just highlighted, this is an absolutely important one, and one that would probably justify a whole webinar on its own. So, and what we've seen when looking at this intersection between the public and the private sectors, looking into the PPP arrangements and everything, that equity might not even have been such a huge issue currently. So really in the immediate emergency response, it was rather straightforward that there was an arrangement between a public and a private actor, and it was pretty clear what the supposed outcome, what the objectives were, and in most of the cases those were really reached. But when we look at it more mid and long term, the question would be, what kind of future is being built, or are we building when going through extremely shortened and irregular and not really validated procurement process between public and private actors? And what would this lead to when it comes to the further outlook? Meaning that it could very well be, just as a little bit of a pessimistic scenario here, but what we've seen could very well be that those more intransparent and not so accountable structures could be a precedent for more PPPs to come, not just in health, but in other sectors as well, in other areas really of society. So when we look at who is carrying the risk in a PPP and how are public resources also being invested and what might be the outcome and who's benefiting and who's gaining from those outcomes, there are still a lot more questions to be asked before we can say, well, those PPPs that we've seen during the pandemic should be long-term sustainable, or that they should be role models and examples for what's to come beyond that. And equity again plays a huge question in all of this, especially.
Thank you so much, Florian. You know, I think at the onset of the pandemic, actually, we had a couple of issues with regards to equity, letting down in some countries vulnerable population. Think about the sluggish procurement of personal protective equipment, and in particular in hospitals, of course, and in nursing homes, and exposing this vulnerable population then to the virus. I think we can learn quite a lot from your research and from improving here public procurement issues. Thanks. Jim, please. Thanks,
Matthias. Just two quick comments from a kind of workforce lens perspective. I think the issue around civil society, I think we mustn't forget that health and care workers are part of the community. They're part of civil society. And in most countries, around about 10% of the working population or more comes from that sector. So we must avoid any sense that there's a them and us emerging. And the key messages around communication to the population at large need to be considered in terms of how the workforce is communicated with as well, because they will often be relied upon locally in communities as leaders in terms of knowing what's going on. So there's a sense in which there needs to be joined up communications there. Second point I'd like to make is more about the recovery area and looking at accessing into new workers. And one of the positive side effects of the pandemic has been that some countries have tapped into refugees that are in the community and have health and care professional qualifications weren't allowed to practice before, but now there is accelerated processes in place to enable them to contribute. It's sad we need a pandemic to allow that to happen, but it's positive that they can now make a longer term contribution where that can be sustained. Second link point, I think what we're seeing in some countries, particularly in the west of the region, is a clear sense that they are now going to be relying very heavily on international recruitment of health professionals from other parts of the globe to make good shortages that have been there before the pandemic and are increasing. So I think in terms of equity, we need to be thinking about equity across the globe, not just within communities and countries.
Very good point, Jim. So the recovery should not be at the expenses of other less affluent regions in the world. And we need that we get the governance, that we get the equity aspect here into our governance, right? And it's of course national, but also international. You know, we have a WHO global code on the ethical recruitment of health personnel. Erica, can you send us into a second quick round of questions?
Yes, I can, absolutely. So some hard questions to finish on. But yes, hopefully we'll have time to cover them all. So one of the questions actually relates to political leadership. So if political leadership is weak, because this is one of the things that we've seen in the pandemic in some countries, political leadership has been weak, is good governance still possible? So that's one of the questions that's sort of come up. Another one is that if where weaknesses in the health system have been highlighted by the pandemic, will we actually learn from this? And will we adapt governance structures, and will we adapt future investment in healthcare to reflect these? What do we think? Do we think that's actually going to happen? Are we hopeful about that, or are we a little bit more cynical? And then if governance is all about trade-offs in terms of transparency, democracy, and things like this, what should be the priority? What should be the key principles to actually guide us in decision-making and implementation? So some very hard questions for you there to finish on.
But they are all forward-looking, actually, you know, because they are all super relevant for the recovery. Kira, please have a first go, but be brief.
Yeah, thank you so much, Matthias and Erica. And I'm actually also following the chat box. And just to my intervention from before, and I think that's also on that recovery bit, can we learn? And I think especially on the engagement with populations, communities, and civil society. And I very much agree to the point that Jim has mentioned before. We need to increase collaboration and modalities, but also, and this is for everyone who's interested, I've put in the link to our recently launched guidance book on social participation for universal health coverage, which exactly wants to make the point of investing in capacities for meaningful and systematic engagement with the population, civil society, and communities. And here, let me mention this. Yes, we are aware that we have different communities, we have different population, ordinary people, and we have to think through a lot more on how we can engage various people with different backgrounds. And this also means sometimes not to let them open a participation on online, but even going to rural areas, to particularly vulnerable population groups, to interact with them. And I think that's the whole point on recognizing that added value of participation, which is a long way to go.
Thanks a lot, Kira. And I think this is a very strong argument for not falling back into the old governance routines, you know, or moving back into the former comfort zone, but really trying to change arrangements as they are today. Florian, please, very quickly.
Thanks, Matthias. And I would like to pick up on the point of learning, because I think it's really an absolutely essential one here as well. And I mean, us hosting this webinar is, I think, actually one element of this whole learning process there. When we look into the way that governance and governments have been working out, and when we really focus on the PPP question here during COVID and beyond, I think the learnings have been huge already, and they have been written up, they have been analyzed for some extent. But there's also much more to be added to this. What I tried to convene with my presentation really a few minutes back is that we have already seen what PPPs are able to accomplish, how they are able to improve health system performance, how what needs to be done to make sure that they safeguard against inequities and not exacerbate them. And we also need to look into that they are a fundamental aspect of ensuring the public trust in governments when working with the private sector, and hence really also making the whole government response, emergency response, and the public's compliance with that much more robust. On an even broader level to that, I would also say that what we can take out of our research on PPPs during the pandemic already is that there needs to be quite some reshaping on governance frameworks for PPPs, again, holding true both during pandemic or emergency times and during peace times as well. So in short, a lot done already, but much more down the way as well.
So it seems like you are optimistic that we are already on the right path and that we are not falling back into the old bad routines. Thank you so much, Florian. Jim, please.
Yeah, I think I would echo what Florian has said, and specifically from the healthcare workforce perspective, I think there are real opportunities in terms of harnessing and embedding some of the positive changes that have occurred in governance to enable healthcare workforce to be more effective. The huge risk, however, is that there's pushback, that where there's been temporary improvements, those are halted, where legislation has been enacted, it times out, and we revert back to the battle days of doing things the way we used to do. And I think the challenge, therefore, and this must be policy-led but evidence-informed, is to identify, capture, network how these positive changes have led to improvements in care delivery and effectiveness. That's the key message that must come through, not allowing a default back to the way we used to do things.
Thank you so much. Thank you so much for all the contribution. I think it has become really clear, we're zooming in on particular topics, that governance is a key leader to not only to respond to the pandemic, but also to build back better and to strengthen health systems resilience. And we must not fall back into the old routines, but we really need to strengthen the governance. And talking about governance, there's a link to government. And I have to make a very special announcement for next week, because the webinar next week on 12th October will be a little bit later. We will start as 1:30, and we will have a full hour until 2:30. And we will include, podcast, we will be directly linked to the informal ministerial council meeting, and we will discuss European support for improving health and care systems. So all the instruments that are available at European level, how can they actually contribute to strengthen the health systems that we now see? And you all know that we have a recovery and facility with a lot of money, and that helps probably strengthening digitalization and other issues, but we want to see the whole picture, what is available, how can we strengthen now our health systems. And as I said, we will have from Ljubljana the Slovene minister, but also we are hoping to have other ministers and ministerial delegations. And also connected will be Maya Matthew from the European Commission and Stefan Eichwalter from the Austrian Ministry of Health, who has first-hand experience of using those monies available on European level. So thank you so much. Tune in next week, 1:30, and hope to see you there. Bye-bye.